Okay. So thanks very much for the opportunity, Akil. Thanks for the opportunity to share some ideas. We say in the Global Newborn Society, every baby counts. And I think it's extremely important to understand how many babies die at birth. In many developing countries, 1 out of 10 babies die on the first day of life. And that many times doesn't include the stillbirth. So greetings from Birmingham, the other Birmingham, Alabama. It's great to be here today. And I'd like to, as part of my presentation, honor Hans Rosling. So I wrote here, in admiration of Hans Rosling, professor of international health, who taught courses on health systems in resource-poor settings and data visualization. So great to be here. He had worked at Karolinska Institute and Uppsala University. And I will not show this TED Talk, but he has 8 TED Talks. And I invite you to watch those. He developed a pre-test for global health, and I'll ask you today, which countries have the highest child mortality? And think about yourself. When I got this question, I got only 3 answers correctly. Highest mortality is Turkey versus Sri Lanka, Poland, Russia, Pakistan, South Africa. And our biases may not allow us to distinguish those and to have the correct answers. Students here at the Uppsala University had actually a lower than average. If you guess, it would be 2.5. So, but that shows the bias that we all have. But chimpanzees don't have that bias, so we assign a 2.5. Interestingly, professors have also bias, Professors also have a bias, and we all have biases. So I think these are the biases that may not allow us to make big progress in medicine, because we have ideas that don't coincide with the truth. So I have no conflict, and we'll discuss the contribution of neonatal mortality and stillbirth in developing countries. I want to sort of equate stillbirth, mostly because most of them are fresh stillbirth. Many of the databases are not prospective, many of the reports, but in the global network, we have a database with 1 million babies from inception of pregnancy as much as possible, but throughout pregnancy, and fresh stillbirth accounts for 87% of the stillbirth throughout pregnancy, not just at delivery. And numbers of stillbirth frequencies have been 33, 35%. If you look at the whole pregnancy and count all the stillbirth, it's probably up to 2/3 or 3/4 or 4/5 are fresh stillbirth. And these fresh stillbirth frequently have a high rate. They just don't get resuscitated or don't get resuscitated effectively. So the second, we'll talk about the essential newborn care programs and neonatal resuscitation, and finally other interventions that can reduce perinatal mortality. But it's not been always that babies were taken care of. So in ancient times, the Greek killed their babies if they were, I was to use a new term, small vulnerable neonates. They would just actively kill them. And the Romans were not much ahead, because they would leave the baby on the ground, deliver the baby, and if it was not healthy looking, they put it aside. That's why in English and in many languages we talk about to raise a child, because they were literally raised from the ground and given care. And it was not in the middle of the 19th century, beginnings of 19th century, when France or Germany came up with the incubators that were a little bit more advanced. They were keeping babies warm before, and Sweden has been one of the countries that for centuries have kept babies warm. They have a tradition, obviously because of the cold weather, but they have a fantastic tradition of keeping babies warm. And then reading the history of this, Mexico, interestingly, was one of the first countries also to develop incubators. And so what happened to neonatology in 1963, as you recall, Patrick Bouvier Kennedy was born premature, 34-weeker, and died. And then the U.S. and also the whole world said, wow, babies die at birth. A lot of people, even professors in a university, are surprised to see that babies can be sick in the ICU. Our biggest ICU is the neonatal ICU, not the adult ICU. And they are surprised that babies can be so sick. And 98%, imagine this, 98% of the babies who die from stillbirth or neonatal death die in developing countries. And there are many causes that we will address, and I will emphasize the neonatal one. Look at this. Neonatal mortality accounts for 44% of all the deaths up to 5 years of age. So it's a huge proportion. And then the other 6% are actually sequela of being a sick newborn. So there's a high mortality that starts at birth. So these are numbers and the causes. You can see being preterm is the number one cause, and birth asphyxia is the second cause. I will address today both interventions that we have worked on. And in this slide that shows different conditions, and they will be enlarged later, it shows the reduction in the last, from 2000, in the decade of 2000, the reduction, and the green is big reductions in mortality from pneumonia, diarrhea, and measles, but small reductions in neonatal problems. So many of the deaths, the neonatal deaths are increasing in proportion of childhood death. And these deaths occur in Africa. You would expect that because they're very poor. But I will show today that one can reduce mortality even though the countries remain poor. And I'll actually show a video of Hans Rosling. I will not show this video fully, but I will start a little bit and then stop it.
Honorin avait diffusé sur
so these are a French artist who supports reduction of death from birth asphyxia, and I will skip it a little bit, and I will show the resuscitation of a baby, and I will skip most of it. You can put the volume up a little bit. So the nurse goes to get water to stimulate the baby. Okay. So the nurse went to get water, stimulate the baby, look at some stimulation but not appropriate, like slapping the baby. And I will not show the whole video. Watch it on YouTube. It's fantastic, and it shows you how our biases produce poor resuscitation. the nurse injects the medication, the nurse does other things, and what they do last, and it works, is ventilation. Okay, how do I switch back to the presentation? I need the video person. How do we switch back to the presentation? Yeah. I'm afraid of making a mistake here. Oh. They disconnected. Oh, the battery may be dead.
Oh, maybe.
Yeah, I mentioned that the battery was low. I mentioned it, but it died, I think. Let me just keep going. While we fix the audiovisual here, I'll keep going. Then there's a video of an elephant. It does a better job doing resuscitation, calls for help, stimulates, and finally ventilates the calf. Amazing. It makes a big sound. It's a battery that was low. It has to be connected. Yeah. So in nature, again, like the chimpanzee, they don't have that bias, and they produce better results. And I thought this video was not real. Yeah. Okay. So how do I change back to the top? Are we okay? And I press here, it doesn't go forward. So I didn't know it was true. So we did a survey of practices before we started to teach people how to do resuscitation. And we were appalled because most of the practices were very ineffective, like smells, like sprinkling of water, like putting your hands over the baby. Those things didn't work, obviously. Yeah. Okay, let me see. Yeah. And I will not show the elephant, but it's on the internet. So we thought we should introduce a package of interventions. So I will emphasize a package of interventions rather than distinct intervention. And I will emphasize teaching, because we can change the world with teaching. You teach someone, and for the rest of their lives, they have the knowledge. So it's not a medication, it's not something complicated, it's simple teaching. And Essential Newborn Care program has a component of neonatal resuscitation. We tested the teaching program of WHO Essential Newborn Care. It did not have a big emphasis on resuscitation. And this one is now called ENC1. This one that includes other things: routine care, breastfeeding, KMC, small baby care, thermoregulation, is part of ENC2 now. And then NRP was simplified. And this is the result, and I'll talk more in my lecture this afternoon in the workshops. When we started working there, the historic baseline just a year before was 95 per thousand stillbirth. Very high, and I told you 10% because 10% of the babies are thought to be apneic at birth. So this confirms that so many were stillbirth. What is really interesting is that this were deliveries or normal pregnancies. If there was any risk, like preeclampsia, infant of a diabetic mother, fetal distress, they were sent out from the first level care, level 1 care, to the level 3 care. So, and you can see here, as we introduce ENC and NRP, you can see the huge effect on neonatal mortality. Stillbirth didn't get any better because we had already told them you have to back, and these are trained, college-trained midwives. So this is the opportunity in the world. This is a design called active baseline design. So it's a very high level of evidence. It's not a pre-post. And we can go into the details in the workshop, but it's comparable to a randomized control trial, like a step wedge. This is like a step wedge design. But most of the perinatal mortality occurs in deliveries at home. This is the clinics, this is a follow-up program, or follow-up clinics that we have in Zambia. With those limited resources, you would understand, when we started to work in there, about 80% of the births were at home, actually. And I show you data to support that also in multiple countries. This is a study of multiple countries, and you can see here pre and post ENC. And this is active baseline again, so this is not historical pre. Actually, the editors of New England Journal of Medicine question it. What's this active baseline? We've never heard of this. But it's like a randomized control trial in which you have to have an active baseline. So that period of pre-ENC is after teaching everything else but the intervention. And you can see 59,000 in this case. The consented ones were the ones below, above 1,500 grams. And you can see there is the 7-day follow-up, 99% follow-up. This is incredible, 9%. It's only 1 week later. But the usual follow-up before we started our study in Zambia was about 50% at 1 week. And the stillbirth was the biggest reduction in these settings. So these are settings where traditional birth attendants are the ones providing the care. And you can see a reduction by a third, 33% reduction in stillbirth. These are all stillbirth, not just fresh stillbirth. These are all stillbirth. So you can see what big of an impact you can have in a low-resource setting by teaching the birth attendants. In India, with what is it? The DICE, the ones that are taught to deliver in India. What's the name? DIE, yep. Mm-hmm. So we taught the DIE, and they had been trained, but you see, this included India also. This is done in India, Pakistan, DRC, Kenya, Zambia, and Guatemala. Interestingly, all-cause neonatal mortality, 7-day early neonatal mortality, didn't get affected. Why? Because some of the stillbirth will die, and some that were not stillbirth will survive. But it's important because you save these babies and there's not an increase in mortality later. And perinatal mortality didn't decrease, and that was a primary outcome of the trial. So the way New England Journal of Medicine requires you to report this is no benefit of the study. Okay? But this is extremely important. This was an intention to treat study. So we had 19% of the babies delivered by the mother, obviously not trained by us. But you can see here, if delivered by a trained birth attendant, there was a 22% reduction in perinatal mortality. That's a big deal. That's a big, big effect. And you can see here, all the birth attendants, including the family, Why? Because they had heard that you could stimulate the babies to breathe. And you can see the traditional birth attendants, the nurse midwives, they learned so much. The physician had an increase, but it's not that we put a poor job. It's that the nurses many times identify babies that have to be sent to the physicians, which was good, and we recommended that. I'll mention other major studies. So this study replicated what we did. But I tell you a problem with some studies. This is the Better Birth study that used the WHO Safe Childbirth Checklist. So this is a checklist of about 40 aspects of the care of babies. And you see here Atul Gawande. He's written the Checklist Manifesto book. He has developed a lot of checklists for surgery. So he tested the checklist developed by the WHO. And implemented it in India with coaching and implementation. So for the whole period, they were trying to intervene with having support. So for each baby that was being delivered, there was a person there and a person supporting it, okay? Results, no difference. No difference in mortality. This is extremely important because if you're not focused, if you focus on 40 things, you're not really focused on any. The part of resuscitation that was taught is, do you have a bag and mask? It's not how effectively you use it. Do you have a bag and mask? And then there's another program just published this year in Tanzania. It's a cluster randomized control trial. Stillbirth didn't work. To me, this is really interesting. I think they may have been working in more advanced facilities, but stillbirth reduction was not present, but neonatal, first day neonatal mortality worked. And this is perinatal mortality, it worked. There are simple steps to improve outcome of neonatal resuscitation. There's a paper by Elizabeth Foglia identifying the aspects, and this applies to low and to high middle income countries. There are other interventions that have been done, and I'll mention two of them specifically because there's a very high level of evidence. Antenatal steroids and KMC. The WHO Action Trials collaborator did this study in Bangladesh, India, Kenya, Nigeria, and Pakistan. 2,800 women, preterm labor from 26 to 33 weeks. And you can see here a big reduction in neonatal mortality, in perinatal death, in early death, and in maternal infection, which is interesting because the thought has been that it increases infection. Well, interestingly, not in low resource settings. And that may be issue of delaying delivery or intervening instrument in delivery. Multiple exams. And WHO also did the immediate KMC study. This was again multi-center study of babies 1,000 to 1,800 grams. And you can see also reduction of neonatal death, as well as reduction in hypothermia and sepsis. And this work in all the subgroups, as you can see here. So it's so easy to change the world. It's so easy, simple interventions that I mentioned it. So why are we not going for the action? What are we waiting for in so many countries that there's so many babies that still die and they could be saved with very simple, extremely low-cost interventions? So there's a lot of evidence of KMC, for example. So I just wanted to mention that there's a meta-analysis on this. And I think it's appropriate to mention today the Nobel Prize winner in literature in 1945, Gabriela Mistral, Chilean, and she said, many of the things we need can wait. The child cannot. To him, we cannot answer tomorrow. His name is today. So I think and appropriate that we show this video. I started late, so I assume I have a few more minutes. The meeting started late. So I'll show 200 countries in 200 years, a video by Hans Rosling, who spoke in this setting right here, and who worked both here and in Stockholm. And again, I think, how do you do it to make it work last time? Well, let me see. Let me see if I can. I tried this one, so this one worked. Okay.
Visualization is right at the heart of my own work too. I teach global health. And I know having the data is not enough. I have to show it in ways people both enjoy and understand. Now, I'm going to try something I've never done before. Animating the data in real space. With a bit of technical assistance from the crew.
Can you hear?
So, here we go. First, an axis for health. Life expectancy. From 25 years to 75 years. And down here, an axis for wealth. Income per person. $400,000, $4,000, and $40,000. So down here is poor and sick, and up here is rich and healthy. Now, I'm going to show you the world 200 years ago, in 1810. Here come all the countries. Europe brown, Asia red, Middle East green, Africa south of Sahara blue, and the Americas yellow. And the size of the country bubbles show the size of the population. And in 1810, it was pretty crowded down there, wasn't it? All countries were sick and poor. Life expectancy were below 40 in all countries. And only UK and the Netherlands were slightly better off, but not much. And now, why start the world? The Industrial Revolution makes countries in Europe and elsewhere move away from the rest. But the colonized countries in Asia and Africa, they are stuck down there. And eventually, the Western countries get healthier and healthier. And now we slow down to show the impact of the First World War and the Spanish flu epidemic. What a catastrophe! And now I speed up through the 1920s and the 1930s. And in spite of the Great Depression, Western countries forge on towards greater wealth and health. Japan and some others try to follow, but most countries stay down here. Now, after the tragedies of the Second World War, we stop a bit to look at the world in 1948. 1948 was a great year. The war was over, Sweden topped the medal table at the Winter Olympics, and I was born. But the differences between the countries of the world was wider than ever. The United States was in the front, Japan was catching up. Brazil was way behind, Iran was getting a little richer from oil, but still had short lives. And the Asian giants, China, India, Pakistan, Bangladesh and Indonesia, they were still poor and sick down here. But look what is about to happen. Here we go again. In my lifetime, former colonies gained independence, and then finally they started to get healthier and healthier and healthier. And in the 1970s, then countries in Asia and Latin America started to catch up with the Western countries. They became the emerging economies. Some in Africa follows. Some Africans were stuck in civil war and others hit by HIV. And now we can see the world today in the most up-to-date statistics. Most people today live in the middle, but there are huge differences at the same time between the best of countries and the worst of countries. And there are also huge inequalities within countries. These bubbles show country averages, but I can split them. Take China. I can split it into provinces. There goes Shanghai. It has the same wealth and health as Italy today. And there is the poor inland province Guizhou. It is like Pakistan. And if I split it further, the rural parts are like Ghana in Africa.
And yet, despite the enormous disparities today, we have seen 200 years of remarkable progress. That huge historical gap between the West and the rest is now closing. We have become an entirely new converging world. And I see a clear trend into the future. With aid, trade, green technology and peace, it's fully possible that everyone can make it to the healthy, wealthy corner.
Well, what you have seen in the last few minutes is a story of 200 countries shown over 200 years and beyond. It involved plotting of 120,000 numbers. Pretty neat, huh?
Very impressive, no? And then he has recently, or later he published this one, a TED Talk. He presented a TED Talk saying we're winning the war against child mortality. But I would say, trying to imitate him, what a catastrophe that neonates are still dying. We have to make an impact. And Dr. Moises Quiles will present the work in Zambia, where we have increased life expectancy from the lowest in Africa to one of the higher ones in Africa. In Zambia, that is a very poor country, we increased, or the life expectancy increased, let's say, in 25 years since we've been working there, increased by 25. So it's 65 right now, with little cost. So I would say one should be compelled by the need of the poorest of the poor and the abandoned sick. In many countries, the sick are abandoned. What will be the chance of survival for babies in the poorest settings worldwide in the future? So what do we expect? Abraham Lincoln said the best way to predict the future is to create it. It's being created in Mexico, for example, with brigadas casa por casa, so going from house to house to support the mother, the pregnancy in the community. And imagine a day when every newly born baby in the world gets a chance to live, even if the baby appears to be dead at birth. This is meant to be, is Vivek Shukla, one of our PhD in AI, neonatologist. I asked him to envision, to get an image of what a low resource setting NICU could look like in the future. Look at the panels, the solar panels, and the baby there getting bag and mask. That's going to be the future. That will always happen. To summarize, these programs that were developed by WHO and the Academy of Pediatrics are now called ENC1 and ENC2 programs. They're very simple. They've changed names, but they're very, very simple and very effective. These are called packages of intervention. It's not new. It's not new. They have been analyzed before, and I'll show you how effective are packages of intervention. This is an analysis by Sulfi Butta and Dr. Black. These are like world experts in counting lives, and it shows neonatal resuscitation. About 700,000 lives could be saved per year. Detection of childhood illnesses, 670,000. Improvement of nutrition, promoting breastfeeding, 550. But the WHO program until recently was IMCI, that did not include the first or the third components of this. So by adding this first component, resuscitation, and then nutrition, you can save more than 1 million lives every single year. I want to thank the investigators of the global network. There's a partnership between the U.S. and each of these countries that I mentioned. My team there, thanking the NIH and other people who have donated money to do this work, especially the NIH, and to the mothers and our team. And you can see here, these are all traditional birth attendants. In our setting, it was the biggest group in the big study that I mentioned. So I think the future is capacitating the personnel so they can do excellent care. Thank you very much.